Welcome. We have a good number of pathologists and clinicians, clinical pathologists as well. Somebody just joined with an amyloid glomerulus, and I'm excited to see who that one is. Oh, that's Haley. Hi, Haley. Just a few housekeeping things. The list obviously continues to grow as far as people who just want to be aware that they happen. So if you need a permanent invite to be on the distribution list, like the email says, they are the third Tuesdays of every month at this time slot, which is 1 p.m. my time in Eastern time zone. Feel free to either add to the chat that you would like to be added. Please provide your email address as well. And I will be able to save that through the chat or directly email me as well. And we'll make sure you are on the distribution list. I try my best to send out a case request the week before so that people who know they've had an interesting biopsy that they would like to discuss, or even a pathologist that might see something really strange on the autopsy floor and they want a quick gee whiz, feel free to send me a case. We usually get through one good clinical case, like a meaty clinical case, and then a gee whiz each month. And a lot of times for the clinicians that are here, sometimes it's, you get a final report and or maybe you get a prelim and you're like, this sounds like a great case for kidney rounds. So you can always email me directly once you get the report. I think we have at least one case slotted for next month, which is a very unusual case from AMC in New York. So we at least have one set case to discuss. So definitely rounds will be happening in February as well. If I do not get case requests, I usually cancel the rounds because it's not really my purview to drive all these things. I hope that the clinicians and the attendees are the ones that get to select which cases should be discussed. Okay. Okay, so we actually have, I know I said we had like a follow-up and then an interesting case. It turns out we have two interesting cases. I know Dr. Shropshire and Dr. Buddy are both on. I don't know if either one of you have time constraints and need to go first. The Shropshire case is the interesting one, which is very confusing. Either of you discussion about when you don't have any time to, okay, so we'll start with Dr. Buddy, since Dr. Shropshire is it has blocked off the whole hour for us. And I know you had said you have a little bit of clinical. I'll just do a quick brief pictures for the pathology, and then you can talk about what's happened since the biopsy, because I think the biopsy was done in September, so we have a lot of follow-up data for that case. Is that a good idea, Dr. Buddy?
Sure. It's just that mine is not super, I mean, it's a cool case as they all are, but it's not a super like weird specific case. I was just like sending it to make sure that the round is actually happening.
Well, I think it would be good for us to talk about what the standard protocol for treatment of some of these cases, because when we get to Dr. Shropshire's case, we're going to ask the question of what should we have done, or what could have been done for this animal. So yeah, I think it would be good to have a good, baseline.
Okay, good. Let me pull up that out.
And I think everybody should be able to share screen, but let me know if you can't. If you need to share screen, you might not need to.
Let me see if it works.
You are good. I can see it. Great.
Perfect. Great. Everybody can see that?
Yep.
Sweet.
At least I
can. So yes, I had Sarge to present. He's a 9-year-old male-neutered German Shepherd, actually a dog of one of our technicians here. And he was first seen by our emergency care September 2nd of last year for acute dysorexia and lethargy. As previous medical history, he only had in December 2020 a history of straining to defecate, hematochezia, and hematuria. And he was found to have an inhomogeneous prostate on ultrasound. So they neutered him and all the symptoms resolved since. And that's sort of the only UPC and urine things that we had. And at that time, the UPC with all these changes was 0.7. And so when he was admitted in September 2nd of last year, he had a normal blood pressure, no weight loss, but he was azotemic with a BUN of 97 and a creatinine of 3.8, and his albumin was low at 2.2. On his CBC, he was non-azotemic, but he had a decreased platelet count at 151. And he had weird, like occasional medium-sized lymphocytes that had a distorted nuclei, and they were not completely able to rule out neoplasia, but they were more looking reactive. On the UA, we had 3+ protein with an inactive sediment, no growth on the urine culture, and his UPC at that time was 5. His abdominal ultrasound was very boring with no real abnormalities, and he was hospitalized for 2 days with our emergency care on intravenous fluids. He was then, after these 2 days, sent home with ampicillin 3 times a day, benazepril and Serenia, and was recommended to recheck the blood work 4 days later. And in the meantime, she looped out and circled back with me and asked my opinion about the case. So we did a little bit more tests, and this dog never had a 4DX. It turns out he was Lyme and anaplasma positive. The downside is that we never had a previous one, so we don't really know if it's previous exposure, but with the low platelet and the fact that suddenly out of the blue he has this azotemic PLN, we were obviously concerned that it may have been Lyme triggered. His lepto titers were negative. His recheck kidney values and albumin level were quite stable. Blood pressure was still normal. And so since he is insured, I highly recommended her to do kidney biopsies. And so that's what we did with a 16 gauge since he's a big dog. And we took 2 biopsies of his left kidney. We only had scant self-limiting bleeding after that, and PCV pre and post was quite stable at 42% pre and 39% post. Waiting for the results, we sent him home with doxycycline for a month to cover for his Lyme, clopidogrel once a day, and Serenia and ondansetron.
Okay.
And so that was the 7th. Yeah. And just to emphasize how amazing you guys are, I actually received a preliminary that was the 11th. So 4 days later, sometimes people are saying, oh, it's not worth sampling because it takes so long to have results. But we actually had a preliminary 4 days later for this patient. So that was quite amazing.
Yeah, and for those of you who are familiar with our service, we have had a little bit of a backlog when it comes to electron microscopy. We are getting a workaround for that kind of established. But even so, just having a little bit of information from the light microscopy can be very helpful because we can tell you how much scar there is. Sometimes like this case, we could kind of give you a presumptive diagnosis, and I can show you some photos of that. But we try our best to communicate as soon as we find something. And then also just being sending us an email, pinging us if you need an update. We are happy to at least give you guys the information about what we have at that time. So I can
Rachel,
show you.
Do you mind if I just chime in there real quick about that? So yeah, as Rachel said, we've got a bit of a backlog with the TEM, but or maybe more than a bit of a backlog with TEM. And I'm trying really hard to get an additional workaround, but I'm having some difficulties there. We are moving faster now with the IFs though, which is good. And so we are keeping up pretty well with the IFs and the light microscopy. So if nothing else, we can definitely provide as much information as possible, as quick as possible. And as Dr. Cianciolo said, feel free to email her, but you can also email me, and I can usually potentially sometimes answer a little faster than Dr. Cianciolo on normal business days. Okay, thanks, sorry.
Yeah, thank you so much for that. So and again, for those of you who are friends, also send me a text. I have no problem with answering text. Actually, I'm a lot better via text. So just to give you an idea of what this dog was dealing with. So we're just gonna quickly go through some of these photos. The glomeruli themselves, they fill Bowman's capsule. there are too many nuclei in here. And then the next question you have to ask yourself is, where are those nuclei located? There's already seeming to be some podocyte damage because you can already see some synechia between the tufts and Bowman's capsule. This particular one has a lot of pink material kind of near 5 p.m. on that glomerulus. That is probably plasma that's being pushed into a location it shouldn't be. I'm going to hop to the PAS to give you a better localization of where the hypercellularity is. Oops, sorry, I didn't mean to do that. I was trying to get rid of this chat. Sorry, get rid of the chat. There are nuclei that are completely encased and entrapped in the mesangium. So these have to be mesangial cell hypercellularity or mesangial hypercellularity. But the other, and actually you can see a mitotic figure up here. I think I even missed that. That actually even might be a podocyte or prial epithelial cell undergoing mitosis. Very uncommon to see that, but every so often we do. And then just the fact that you really can't see good open capillary loops in many of this glomerulus. So we have multiple nuclei hanging out in this one small piece of lumen. And if you go down to this glomerulus, you can actually start to see the glomerular capillary loops pop out a little bit better. But we have this combination of mesangial and endocapillary hypercellularity, which is, it's often an overlap. There are cases where you might just have mesangial cell, but usually in a lot of glomerulonephritis cases, you'll see cells everywhere. They'll be in the capillary lumens, they'll be in the mesangium. And it's really just hard to say. I can't find a very good patent open blood-filled, like there's no red blood cells in here to tell me it's a good patent capillary. This little squiggly nucleus here is probably a neutrophil. And again, we have that PAS positive material that's being pushed out into the matrix, and that is hyalinosis. The trichrome is again, going to show us where there is collagen. That is going to be the blue. The red is going to be the nuclei. And actually, this is a good photo to already see. You can see these red little dit dots along the capillary wall. Here's another area, kind of almost like gets assumed into that. It gets kind of takes on the shape of that wall. You should not have red material along the glomerular capillaries. And that's quite suspicious for having immune complexes. And even this one, all these red dots up here near 12 o'clock are probably immune complexes. And we have these more dit dots down here that are probably immune complexes as well. So even with the histology, I was pretty certain that we were going to have immune complex disease. Also, it helped me that I had the clinical history, that the dog had a lot of infectious disease titers. For the pathologists who don't see that many kidneys, leptospirosis is not a disease that I worry about for glomerular disease. This dog was leptonegative, but I do worry about tick-borne diseases being the nidus or the original inciter for making immunoglobulins that then will get deposited in the glomerulus. The Jones stain is going to show me how the glomerular basement membrane is reacting to the deposits. So having these double lines here makes me realize that that little tiny pink bleb is probably where a deposit is. The deposits don't stain with the silver, but the GBM does. So I have a little encased deposit probably right here. And if I go through more of the Jones stains, I'll start to pick up these little like tiny holes where the deposits are probably located. So I was already sure we pretty much have a membranoproliferative pattern. Membrano meaning that the GBM was thickened and remodeling. That's what membrano means. It's thick, it's remodeled. Proliferative meaning it's hypercellular, and it doesn't necessarily tell me where the hypercellularity is. If it's limited to the mesangium, then I call it mesangioproliferative glomerulonephritis. But if it is in the mesangium and in the capillary lumens, then I say membranoproliferative glomerulonephritis. If it's just GBM remodeling and thickening and these little holes that are probably surrounding deposits, then I say it's membranous glomerulonephritis. And so look at all of these nuclei hanging out here. You can barely even see mesangial matrix on this particular thing. So I was it was definitive. I knew what we had. The IF was a little annoying, and I'm going to say that because it just didn't stain the way we wanted it to. We had a situation where we were like, well, we just moved to Texas A&M. We're just starting to do the IF there. And we're kind of learning the ins and outs of how they're cutting the section. So even though I didn't see really great positive staining on the glomeruli for IF, and I also don't think we had that many glomeruli in the sample. I'll have to look back at the report. But I was thinking that was probably lab error and not necessarily true results for the IF staining. Let's see if I can make sure you're still seeing the right thing. Now you should be seeing EMs. Okay, so even with the fact that I wasn't entirely sure why the IF wasn't staining positively, we have the electron microscopy that can be the reliable gold standard for the diagnosis. So the excellent thing, the thing I like about kidneys is you have 3 different studies and they all seem to either support one another, or if one of them's an off situation, then we discuss why it could be off. In this certain situation, we think, well, it's probably because the IF wasn't optimized yet at Texas A&M, but the EM was. So we're happy with our gold standard. So we have, we're looking for electron densities that are associated with the glomerular basement membrane. And for those of you who are training as pathologists, this glomerulus is hard to actually outline the GBM because it's so wrinkled. This is probably a glomerulus that has partial sclerosis. So we're looking at this stuff here. Hopefully you guys can see my arrow. Dr. Betty, can you nod if you're seeing my arrow? Okay, perfect. So I'm following the glomerular basement membrane. This over here is mesangium, probably maybe at the base of the capillary loop. This is a red blood cell over here. The GBM is just very squiggly, for a better word, but you can start to see these electron densities kind of within the GBM itself. Sometimes they are subendothelial, which this one is because this is endothelial, a blob of endothelial cytoplasm. So we definitely have these electron dense deposits. And the hardest thing I think for me when I was starting to learn how to do this was how to distinguish electron dense deposits from hyaline. So that's that PAS positive material that got pushed into that edge of that glomerulus that I focused on in one of the photos. That's just plasma. I mean, it's just material that's coming from the blood. The GBM can kind of entrap it, or it can be pushed into the GBM. It can also get pushed into mesangium. We often think that means that the endothelial cells have been damaged. So trying to figure out whether this is probably hyalinosis versus an immune complex is kind of where you have to go back and forth. There are, in this situation, a scenario where we have both immune complexes and hyaline, so based on histology, so we're okay with maybe not always being 100% saying which one's hyaline versus immune deposits. This next photo, again, we're seeing these electron dense deposits in a subendothelial location. We follow the glomerular basement membrane up here, and we have more electron dense deposits up here. And I'm just kind of looking at the montages for this. We have a few intramembranous deposits in this capillary loop as well. This is probably one of our most well-perfused capillary loops in this glomerulus. You can see these 2 dark squished structures. Those are red blood cells. So think about trying to perfuse this glomerulus, and they're trying to squish through this little narrowed capillary lumen. The reason they're narrowed is because we have all of this kind of almost electron lucent material, and this is all cytoplasm of the endothelial cells. So the endothelial cells themselves are really swollen and damaged, usually in response to the presence of deposits. And so that makes the lumen stenotic, and then it's hard to perfuse those capillaries, and that's why we have these kind of squished, misshapen red cells. Oftentimes in humans, it's kind of easy to pick this up as a diagnostic feature because those red blood cells, when they get urinated out, have an abnormal shape. And so that could just show you there's endothelial damage. It doesn't necessarily tell you it's immune complex mediated, but it tells you the glomerular capillaries are pretty damaged. And that's why you're getting all these kind of red cells as they get pushed through the the capillary lumens, they tend to like break. These capillary lumens can break, and then you can have red cells out into the tubular lumens as well. And then just more electron dense deposits in here. And then also for pathologists, if I keep telling you that these deposits are, in a subendothelial location like this one is, this one's probably intramembranous. That means that the endothelial cell is on the left side of this picture and the podocyte is on the right side of the picture. It can be very difficult in these cases to say exactly where the podocytes are. They don't jump out at you unless you do this frequently, unless you do these kinds of images frequently. But all of these here are podocytes that are really swollen and they've lost their foot processes. They're no longer able to maintain their foot processes. And so they kind of basically meld with the foot process that is either next to it, or they can just basically blow up. So now they're just squished against the glomerular base membrane. So we have podocyte injury, we have endothelial cell injury, we have electron dense deposits. So it fits with a membranoproliferative glomerulonephritis. And I will stop here. And if you want to talk about how you worked on the treatment for this case, Dr. Buddy.
Absolutely. So we finished the month course of doxycycline to make sure that all of the potential Lyme triggered was cleared. And let me see where I'm at here. And so as soon as we received your preliminary, basically quite suspicious for an immune-mediated disease, as we were suspecting clinically as well, we started him on mycophenolate and continued the clopidogrel, the doxycycline for a month to make sure that we clear out any potential Lyme triggering this immune response, and also keeping in the back of our head the potential anaplasma that could have caused also the decreased amount of platelets. So all of that went back to normal on this treatment, and we needed to add some GI support as well to make sure that he was tolerating his mycophenolate. And this is sort of the different graph of the follow-up since the first admission and the biopsies, and sort of where we are at with him currently. So regarding his azotemia, we were able to go down from a creatinine of 3.8 to, we are currently sort of plateauing around between 1.8 to 2. But his USG is quite good, so we may have a component of pre-renal as well. We made a nice improvement with the albumin as well, that went as low as 1.7, but we are just in the low norms between 2.7 and 2.8 currently. And the UPC went nicely down, up even to 0.9. I am suspicious she was not able to give as well as she was to the mycophenolate for a little bit. So I wonder if that may explain why we have a little re-increase here, but we are again nicely trending down and plateauing around a UPC of 2. And so we just added, now that his kidney values are quite stable, we added telmisartan to see if that could make any improvement on top of what we reached. Theoretically, ideally, therapeutically speaking, we are saying that we should be happy with a decrease of 50%, but obviously we are always trying to reach for even better than that and see if down the road he's going to be able to go even lower than a UPC of 1.9.
And it sounds like Dr. Vaden had a question, and it sounds like you answered it, was about getting a RAS inhibitor. So you added that more recently.
Exactly. So we added that about 2 weeks ago now, sort of trying to, first, I was a little bit concerned to start right away with his azotemia, making sure that the azotemia was getting back into a better situation, a more stable situation. Also, these are sometimes quite difficult cases in the sense that if it is immune mediated, we need to start them on mycophenolate. Mycophenolate is renally excreted, so they can sometimes get really sick from the mix of the azotemia that they're not used to, mycophenolate causing side effect on top of that. So he was definitely a case where we had to really slowly go up on his mycophenolate dose to reach the full therapeutical dose, and really going step by step to make sure that we were not clinically making him worse with the treatment. And so that's sort of where we are with him right now.
And so I think that this does illustrate cases where these animals do improve. I know I still talk to a lot of pathologists and probably even practitioners that trained a while ago that feel like these are all cases where there is no, well, no, it's a difficult disease to manage, and they all kind of go down in a ball of flames. And agree, some of them do go down in a ball of flames, but there are plenty of times where we get clinical improvement and better quality of life, and the dog feels a lot better, and the cat feels a lot better, and we can get, we know whether or not we get back to baseline or whether we get back to completely normal, we can at least plateau at a stage where they might be a CKD dog. And we know what the original inciting cause of that CKD is. And so we manage the CKD dog once we know we're back to kind of that plateau. That leads me to the question, which actually is kind of as I kind of transition from one case to the next, unless anybody has more questions about this particular case of management of a disease where we know the inciting cause was probably tick-borne associated immune complex deposition in the glomeruli. We actually have that answer, and we have the comprehensive biopsy to prove it, and then we have the follow-up.
Hey, Rachel,
Yep.
It's Dan. I would agree with you that these cases can go pretty well. And one marker that I like to use is concentrating ability of the urine. That tells me that these patients have tubular function. Sometimes we need to give Lasix to, deal with overhydration and things like that. So, excuse me one sec. Sorry.
Yeah, and I think that that is a scenario where, if the dog wasn't able to concentrate, then we'd be a lot more worried about that creatinine for this patient. And so it does, getting those markers for tubular function is very helpful. There are obviously a lot of novel biomarkers that are also used for evidence of tubular injury, and we don't really have a great one yet for tubular scarring or tubular interstitial scarring. But following those trends, and the trend is often very important, not just what the measurement is at that time, but is it going down and is it consistently going down? And as I'm getting up, Dr. Shropshire, are you going to be willing to talk about your really awful, difficult, I'm saying awful, but it was awful because it was a difficult case?
Yeah, can you hear me okay?
Yes, I can. I'm going to, as I get ready to do it, I also have a question, or not a question, but we have a current clinician in Australia who has a case that's definitive membranous. And we have it based on all the different studies. We don't really know what the inciting antigen that is causing the membranous glomerulonephritis. The dog is doing awful on mycophenolate and just from GI signs. So that'll kind of factor into how do we treat these cases, like Dr. Shropshire's, which is basically going to be, we don't really even know what the diagnosis is or was. The dog ended up being euthanized. So the samples we actually have are autopsy samples. But what's our go-to when things don't seem to be responding to our first line of drugs, which we often grab for immune complex disease, which is mycophenolate. So do you want to start with discussing your case?
Yeah, so, okay, so I apologize, I don't have anything.
We literally emailed about this like 24 hours ago. Don't worry, I don't even have a PowerPoint.
So Scoots was an 8-year-old mini Australian Shepherd, and she had really never been to a vet previously. She had no previous diagnostics ever done that we could go back and look upon, but the owner had noticed she'd been vomiting, not eating well, very, very lethargic, and then kind of found her in the yard just laterally recumbent. So she came in through urgent care, and she was very, very dehydrated, considered hypovolemic. She had, her initial diagnostics were, she had a creatinine of 6.8, her albumin was 2, her cholesterol was 450, her blood pressure was 130, good body condition score overall. And then just for time's sake, I'll kind of fast forward. She had a urinalysis that was, at before fluids 1014, USG with 3+ protein, quiet sediment, negative urine culture, leptonegative, 40X negative. She had was fluid resuscitated with the urgent care very conservatively because the proteinuria and the low albumin was actually found out sooner than normal than what we usually have happen in the ER. And so they started to fluid resuscitate her, and as she got more euvolemic, she actually had hypertension, and she had some fundic lesions as well. So she was like a blood pressure of 190 to 210. So in this time point, we got the UPC back. It was 19.4. We rechecked it just to make sure. I looked at the curve and everything, and it really was severely elevated. Then she had an abdominal ultrasound, which showed that she had bilaterally degenerative changes of her kidneys. They weren't horrid, but they definitely looked like she'd had something chronic going on for a while. And then she also had hyperechoic cortices. Then she had this strange structure near her right ureter that we had ultrasounded, like all the faculty looked at it. And then a visiting radiologist looked at it as well, which is a random backstory, but multiple people are looking at it, said it looks like, you know, probably maybe some hemorrhage from a previous cysto, maybe from steatitis. We actually aspirated the area. It came back acellular. And so we did urine output, you know, ins and outs and all of those things. And she, you know, started to respond clinically with regards to an ACE inhibitor, clopidogrel. We also did start her on steroids after a long discussion with the owner about pros and cons. Not having an SDS page back, the owner couldn't afford a biopsy. We actually used a lot of research funds to actually hospitalize the dog, so we were fairly constrained financially. We talked about doing a CT scan because of this strange structure in case we were missing a neoplastic issue or even a foreign body in that area. And so long story short, you know, we treated her as an immune complex dog. And she, I think her recheck albumin after she was better hydrated was 1.6. Cholesterol was still in the 400s or so. Blood pressure came down very nicely. Her azotemia remained fairly static in the 6s, didn't go up. She started to eat. Her urine output remained polyuric and then became a little bit more normal, and was clinically improving a lot. And so we had her in the hospital for about 6 days, sent her home. We also talked about compounding mycophenolate because of pharmacy issues. I didn't have the availability to have that on hand, so we did steroids while we were waiting for the compounded mycophenolate. She was only 4.4 kilograms, so she's little. And so she went home on, you know, therapy for immune complex GN, and then she also had a PICC line during that time point because, again, all of her vessels were blowing. And when she went home for the weekend, was eating, was playing, seemed fine. And then the owner mentioned she was shaking her back legs, you know, just intermittently kind of shaking them, which I've seen with multiple dogs when they have a thrombus, you know. And we had done 2 vascular studies on her that hadn't shown anything, but this weird structure was really bothering me. I didn't know what that was. And so essentially then her face became extremely swollen, her muzzle and all around her kind of muzzle area and her neck. So of course, then I worried she had a thrombus. And so she came in, we offered, you know, everything, you know, hospitalization, more aggressive therapy, you know, a CT scan, all the things. And she was euthanized due to financial constraints. One thing I wanted to share just on the share screen that I can show you was on gross necropsy, if hopefully I can find it. Let me know if you can see what I am seeing.
I can see open Zoom meetings.
Can you see the image?
I'm not, let me see if I can see.
Not yet, Sarah.
Not yet.
So I'm clearly sharing the wrong one. So let me try again. So on here, let's try that. How about that?
I see a artery.
Okay, yeah. So when we opened her up, this was actually a aneurysm dilation and rupture of her internal iliac. So that's what we were seeing, was a huge thrombus. And so she had thrombi of her internal and external iliac arteries bilaterally.
At the
But on
time
the-
that she came into the hospital originally, this is what you were seeing?
Yeah.
I don't think I
and
got
so-
this piece of information.
Yeah. So that was one of the reasons I wanted to write her up as a case report, was because her imaging is so strange. And once in hindsight, when I showed all our radiologists the postmortem findings, they were like, okay, yeah, I actually, with the Doppler, yeah, we should have been thinking of maybe a thrombus, but you know, aneurysmal thromboembolic disease is so uncommon in dogs. And so no one was actually thinking that the artery was dilated.
Oops, I'm not sure we lost volume, or maybe I'm just the only one that lost it.
I think Sarah's frozen.
Oh, okay. Hopefully she can come back.
She's frozen in an amazing position.
I'm only seeing, oh wait, I'm not seeing her picture.
Here.
There. Oh, no, I don't see her now. Oh, are you there?
Yeah, can you hear me now?
Yes.
That was weird.
Yeah, it just froze randomly at the point when you were talking about that you guys all got to the fact that that was definitely thrombotic disease.
Yeah, so the artery was, you know, when we looked at it histologically, it was dilated and then had ruptured through. And so, which had been present when she first presented. And then we didn't find any thrombi in her face, but we think that's probably what had happened. And then we submitted the biopsies to you guys. And so one of the reasons I wanted to write her up versus as a case report was aneurysmal dilations and ruptures are so uncommon in dogs, and the imaging analysis is pretty interesting. And the radiologists in hindsight said, yeah, I mean, that's probably something we could have considered and didn't. And they just, I think obviously a CT scan would have been really helpful, but we just didn't have the funds. But then when I got the report back, I was like, oh dear, that's very confusing, because we knew probably she had some sort of chronic, I would think, chronic process going on. But then, yeah, it sounds like her biopsies are very odd. So
Yeah, so I'm actually interested, and sorry, remind me again, what's the breed?
a miniature Australian Shepherd, like a
Yeah,
little
so
pig.
I'm
thing.
gonna admit I missed some atherosclerosis now that you've told me about this vascular stuff, and I'm looking back at the kidney, so I will be able to share you. There's a bit of atherosclerosis, a small amount in the kidney, but it might be worthwhile for it. She got a full autopsy with histology as well.
Yes.
So it might be good. I know Becca McKee is on this phone call and she is at Colorado State. So maybe she can pull it and look for some of these things. I don't think that was the ultimate. I mean, there's definitely glomerular stuff going on as well. But I can pick up a few vessels in the kidney which have a little bit of fat deposition in the tunica media. And the reason I was worried about it is because we've reported a few other miniature Australian Shepherds with atherosclerosis that hit all over the body, cerebral vessels. We saw a little bit in the kidney, although the kidney wasn't as big of a deal, but the digital, like it went into like the legs, and we had atherosclerosis there as well, and ruptured vessels and thrombotic disease in that. So
Oh, wow. Yeah.
yeah. And did you have, what was the cholesterol we have from Dr. Conkin, who likes vascular disease?
3.
Oops, you froze again, maybe. Let's see. Unless I'm the frozen one. Oh, she froze. I think I'm still talking. Okay, so
Yeah,
I will at least
Sarah.
share.
Good, Rachel.
Okay, so we have cholesterol around 330 to 410. I'm going to show you some histology. And I'm going to admit that because I'm not a clinical pathologist, that seems on the high end, but not super high, correct? For 330 to 410?
Yeah, and I considered it abnormal in particular because she wasn't eating.
Okay.
You know, she
Okay.
hadn't eaten for about 4 days. She started to eat well while in the hospital, and I checked her cholesterol before she left, just out of curiosity. Her blood was never lipemic. I went and spun it, but we don't have triglycerides on her, I would say. And this is the one that I may have hoarded serum and supernatant, so I still need to look in the freezer because I've been hoarding all of these things for no reason other than just to
No,
have them.
there is reason. There is reason.
Just in case.
Okay, so hopefully you guys can all see a very pink kidney. So I think we had 2 wedges, we bisected them, and all of the pink material, that these blebs right here, those are all going to be tubules that are filled with protein casts. This is definitely a proteinuric dog. I do like to teach my pathology colleagues that just because you don't see protein casts doesn't mean it can't be proteinuric. I remember sitting in rounds before, and we definitely had an MPGN case at the vet school, and the pathologist kind of said it wasn't that important because you didn't see protein casts in the tubules. That is not true. You can have really bad proteinuria and see no protein casts. It would be very uncommon for you to have this many protein casts and not have proteinuria. So it's kind of one would always correlate with the other. Like protein cast is going to correlate with an elevated UPC, but you can have elevated UPCs without having this number of casts. I hope that made sense. But this is a very, very, very damaged kidney with all of these protein casts that are basically sludging up all of the lumens. Another fancy trick is that these ones that are densely pink, these really fuchsia casts, are usually in the lower portion of the nephron. Those are usually in the collecting duct stage. Because that's the region that can make TAM horsefall mucoprotein, also called uromodulin, and that often makes it a very dense proteinuric cast. So you can see when you're looking at these are probably collecting ducts, maybe loop of Henle, but probably collecting ducts. And these ones that are more lighter with this kind of more amorphous soft pink, those are probably proximal tubules, but they're very, very damaged proximal tubules because see how dilated they are. They do not have good brush borders. So we have a lot of proteinuria. We've got a lot of protein casts. The glomeruli, I think we're probably like 40% globally sclerotic or maybe 30% globally sclerotic, but they're definitely abnormal when you're looking at the non-sclerotic glomeruli. That pink material that we saw and we discussed last time about being plasma, this is a hyalinosis on PAS. It's very bright pink. And it gets pushed into spaces it shouldn't be located. So here it's pushed into a glomerular capillary. This area, it's probably a mesangium and capillary. Sometimes you can see it's a little bubbly, and I don't know why, but occasionally hyalinosis looks a little more bubbly than, say, discrete deposits. On the PAS, it's going to be the bright pink material for hyalinosis. And on the trichrome, it's going to usually be a little orangish. Also take note of these really, really messed up podocytes. So podocytes have these podocytes have protein droplets in their cytoplasm. So they're definitely grabbing onto whatever protein is crossing the glomerular basement membrane. We can often pick this up on EM as well. You'll see these really dense globules or vacuoles inside the podocytes. These podocytes are upset. We often say that they're almost trying to detach. They're trying to die. They're basically jumping off the glomerular basement membrane. In comparison to the case we had before from Tufts, we have the sense that there's some hypercellularity, but it's not as striking as our previous case in that German Shepherd. So we have maybe 6 nuclei here, too many, but it's not, the entire glomerular tuft being affected. Let's see what else we can see on this. Again, very, very bright pink material. So on histology, we would have no problem saying that this is hyalinosis. And then trying to figure out, what this material here in the mesangium is that just too much matrix? Is that more plasma? Are those deposits? It's very difficult. And then lastly, while I'm on the PAS, I'm going to focus a little bit on the proximal tubule, The proximal tubules should have a very good brush border. So this one is trying to maintain its brush border. It definitely still has a little bit of the irregularity on the surface, but there's way too much lumen exposed. And that's because we've got loss of the cytoplasm of the proximal tubular epithelial cells. And now we're basically trying to reform or reestablish the previous absorptive capability of the proximal tubule cell. If you compare this one to this proximal tubule that's right next to it, we even have dying cells in this proximal tubule. So we have these nuclei that are really apoptotic or kerarectic sitting there in the middle of the lumen. And then we have the epithelial cells that are kind of crowded around it with a lot of material in their cytoplasm. I will also, since I'm here and I think I circled it on the slide, this is the artery where I missed it. And I mean, it's not, oh, here it is. I was like, no wonder I missed it, wasn't there? Okay, so hopefully you guys can see at this branch point, we've got this, again, foamy, lipid-rich material within the tunica media. And this is probably a branch point for the artery. You can pick this up as well on the H&E. So these little things that are tiny bits of lipid inside the wall. The previous case we published in the mini Australian Shepherd had more luminal or kind of bulging into the lumen. And we had vessels from all over the body. So we had so many vessels to look at. Dr. Konkin was one of the authors that did most of the work on that particular publication. So you have to kind of know, you got to hunt for that caliber. It'd be really hard to kind of pick up in these vessels out here, but maybe you could try to find it in an intralobular vessel, but everything gets so squished out there, it's kind of hard to see where the vessels are. So Becca, if you're able at Colorado State to pull that case and pull the slides, I would look at like the cerebral vessels. I would look at the vessels inside where that thrombus was. I'm assuming they took sections from there, and just see if there's wall damage to the wall as well as the actual thrombus itself. I'm going to quickly go, trying to keep on time. If anybody doesn't know me, I talk really fast. Uh-oh, now we're at the circle spinning wheel of death. What's happening? Okay, trying to load. Okay, here we go. So the trichrome, again, if we're going to look at that hyalinosis material, we want it to be orangish. And you can see that actually it's not really staining all that orange. It's actually staining a little blue, which is a little strange, and which is why this case gets a little more confusing. Sometimes we can see a little bit of orange material along those regions, but like this, sorry. So see how there's like a little bit of pallor, there's a little bit of color change to this material here in the matrix. And so there's something that's not just true basic run-of-the-mill hyalinosis in these glomeruli. There's something else as well. Let's see if we can find that one artery. And it's gonna take a moment to load.
While you're looking, can you just comment on the proteinusis in here, how it's so variable from really bright pink to blue?
Are you trying to ask me which one's which? Because I don't know.
I'm just amazed at how different it can look.
Yeah, so I think that's just I'm in trichromes, we can see that. And that's also kind of the thing that we see a lot of times with like hyaline or amyloid, where it's just probably how much is just run-of-the-mill globular protein that can be more stained with the red that would stain the cytoplasm of some of these cells, or how much of it is other types of protein that just haven't. I haven't done a lot of reading into why trichrome has that almost like changing staining profile, but that's a really good point, Mary. It's very prominent. All right. So basically what happened was I emailed when I saw this to Dr. Shropshire and I said, hey, I think it's probably going to be a chronic MPGN case. We've got some thickened walls. We definitely have scarring. We have all this kind of material out here that I at that time was assuming was kind of just a weird hyalinosis material. We definitely have podocyte injuries. Remember how I said those podocytes on the previous case had the bright pink globules? On this particular glomerulus, we see it with red globules, so it's reabsorbing some kind of protein on into the cytoplasm of these podocytes. So the podocytes, no matter what, are they're shot. They're dying, they're detaching. This dog didn't really have a lot of chance for recovery. So I'm not surprised that things kind of went down the way that they did, because there really was a lot of loss of pre-existing podocytes. So now we have, like, you can pick up the globally sclerotic glomeruli here, here. And then the ones that remain are also losing their podocytes. They are dying, they're detaching, and we have a lot of sclerosis. So it made sense that this dog did not recover well. And I thought this was going to be a run-of-the-mill, straightforward ICGN case. So we went ahead and did everything for this case. I'm trying to find if I can find another artery, but nothing that's really that interesting for me. And I will share that. We have stuff on the, let's see. Yeah, okay. So Becca is asking about glomerulolipidosis. I don't remember seeing a lot of foam cells within these glomeruli. So that's not something that that jumps out in my memory, but I can go back and look at it again. I'm obviously going to take a photo of that little bit of lipid inside that arterial wall. I want to share, where is the EM? Oh, I think I have to do this. 1 second. Here on OneDrive, 1 second. Oh, never mind. Hold on, let me stop sharing this. So the IF was disappointing. The IF was basically a lot of blebs of staining, and it was that the IgM stained more prominently than the other stains. And so IgM is a really sticky antibody when you use it for immunofluorescence. And so it often just kind of adheres when you have hyalinosis, when you have sclerosis. Sometimes when we see a lot of kind of just like non-specific, it looks like it's just like splotchy, it's like a splatter on the IF slide. It is that the IGF stains more prominently. In hyalinosis, you probably do have immunoglobulin proteins that are being pushed into that area. So, so you could see non-specific staining when you just have hyalinosis. But my read on the IGF, the IgG was, it was completely negative. The IgA was completely negative. We had some staining with the let's see. Oh, 1 second. Hold on. I'm actually reading the wrong one. I'm reading the report for Sarge. I apologize. That was inappropriate of me. I was sharing the wrong thing. Here it is. Okay, let me see what the IF for that one is. Did I take pictures? That's the next question. And I can show you the pictures, or yeah, here they are. Okay, so here I'm gonna do is just do it this way. Zoom should beckon to my call. So share screen, share that. Okay. Hopefully you guys are just seeing a picture of the report. So now the IFs are performed at Texas A&M. Jessica Hokamp and her students have gotten very good at running these cases. And so we're in the timeliness of this is pretty quick. So if you look at this IgG, this is a glomerulus here. Really, most of the tuft isn't staining at all. We have a little bit of kind of this, that's what I think it almost looks like a glob of stain in that one area. Now that could have been an area where we were seeing that possible hyalinosis on the histology. The IgM was often more like this, where basically it's so strong, you're not even picking up any of the tubular interstitium. We definitely have a lot of material where those hyalinosis is, but it's also labeling the glomerulus as well. The LLC was kind of a mid-range between the IgG and the IgM, and the C3 was, where is that? C3 was pretty trace to weak, so it wasn't really activating complement a lot. And then since I'm already on here, might as well just do the EMs this way. So on EM, I'm the one that scoped it. We actually did this one at Ohio State. And so I have like 4 glomeruli, and they all had this kind of irregular electron dense material within the capillary walls. And here would be our narrowed capillary lumen. You can't even see a red cell in there. Here's our endothelial cell that would represent the capillary lumen, and we have all this electron dense material. And so I was pretty sure that we either had really, really, bad multiple layers of immune complexes. But then when I looked at the IF really wasn't showing great staining, at least for the IgG. So, and usually we trust the IgG more than we trust the IgM, because the IgM can kind of bind to things non-specifically. Dr. McLeland was the one that read this biopsy, this EM, and she and I discussed it a lot. I discussed it with George, and we were trying to figure out what this material was. So it does seem to be the stuff that does label with IgM, immunoglobulin M, FIT-C antibody. It doesn't seem to be labeling with IgG. There was some degree of staining with lambda, so we know there's some little bit of lambda light chains. It doesn't seem to be overtly activating complement at this stage, but it's all over these glomeruli, and it's definitely that stuff that we were seeing on histology that was kind of pinkish. And so this goes back to Becca McKee's question about why is it so difficult for hyalinosis versus immunoglobulins? Sometimes you answer that question because you have the IF, right? So if you have really good discrete positivity or good chunky staining with the IgG, you would be happy that this is just immune complex disease and it's just really, really bad, because the IgG tells you, oh my gosh, every single capillary loop is labeled, but our IgG was pretty negative. And then you kind of go by pattern, like, does it have bubbles in it? Often, usually hyalinosis will have a little bit of bubbling in it as opposed to immune complexes. Oftentimes, hyalinosis almost just kind of takes the shape of the capillary loop. It almost just it's basically fluid that's being pushed into a prearranged shape. So sometimes it can just basically look like it's almost like pavementing along the capillary loop. And that it can be very where it can be different than deposits which have a little more discrete nature or discrete appearance. And again, this is just me talking about things that I do look at every day, and that's why it's annoying for other people to hear me talk about it, because it's not something that everybody gets that much exposure to. But I was pretty confident that we did have some discrete deposits in some of these capillaries. So I think that there's something there. I think it's labeling with IgM. And then I went on a long discussion about what this could be based on what I know from human medicine. So IgM nephropathy is a thing. It's not really regarded as an actual diagnosis anymore these days. Even though it's been published and it's in the big textbook, nobody really believes it's a thing anymore. So as far as IgM nephropathy is concerned, you would have to have a very, very specific set of criteria, and most nephropathologists don't diagnose that ever for physician nephropathologists. Masked deposits is a thing, and we talked about this at the kidney workshop when we did in Boston. So you can have IgG deposits that this could represent, but they've been cross-linked somehow, not even from formalin, because that really wouldn't do it. But they've had some kind of cross-linked, and so you basically have to partially digest the slide before you re-stain it with immunofluorescence. So that is something we can try. We have to buy the reagent. It's not very difficult to get, but we could buy the reagent and try to re-stain with IgG. And that is something that happens in human medicine. So it's called IgG with masked deposits. And basically you partially digest the slide, you re-stain it, and then they light up like crazy. That's a possibility. The other possibility is when you have something like a cryoglobulin that's causing the glomerulonephritis, that oftentimes can be a monoclonal IgM cryoglobulin. So you do actually have IgM in here, and they're the part that would freeze out when you do the test for cryoglobulinemia in the serum or in the blood, I guess. But we don't have verification this patient had cryoglobulinemia, so that one's hard to say as well. So we got a lot of options. And now in the last minute and a half, for the clinicians in here, how do you guys manage cases when you don't really even know the diagnosis? Was it reasonable to go ahead and start steroids, start mycophenolate, and just hope for the best? I'm muting myself for the clinicians to talk. it sounds like nobody knows what they would have done with this case.
When they are crushing and burning like that, especially mycophenolate takes so long to be fully effective. We may be, sort of pulling the last resort, and I've done a couple of cases with even cyclophosphamide as a, let's try everything and have this immunosuppression kicking in right away, and also avoiding GI side effect in a patient that is already not doing well at all. But yes, that's the downside of mycophenolate, how long it takes on top of the side effect.
Would cyclophosphamide have been another possibility? Does anybody try that one for those ones that are basically, because I've seen vets say that I've started the dog on cyclophosphamide, and usually it's when they're really, really, really sick. And I don't know if we only give cyclophosphamide to the really sick ones and that's why they don't do well, or if people just are uncomfortable using cyclophosphamide.
That's at least my experience. Unfortunately, I've just used them when the crushing and burning. For example, Zeitz that we talked about in the last round, at least he survived 2 months, which was kind of already a miracle that he survived 2 months. But I'm not sure how much the cyclophosphamide helped.
Okay. Well, I think, I do, that kind of leads me, and I know we're a minute over time, but that does lead me to that question that the doctor from Australia said. Basically, the mycophenolate isn't working. I forwarded it to Dr. Foster, who does a lot of consultations for our renal biopsy service. It would be amazing if we can kind of, and I know we talked about this with Dr. Vaden too, like the reason mycophenolate is the go-to first off the shelf is because you guys, the clinicians, needed to settle on something. And that was one that to make sure everybody was at least doing the same thing. So then you could gather a cohort where they have been treated with mycophenolate, and you would actually have that cohort that then you could study. But obviously in humans, they have a lot more options for figuring out and managing these cases. They have drugs that can just stop the complement system. They have drugs that can basically knock out all the B cells. They're not making any more immunoglobulins. So it would be great to have another target that's not just an immunosuppressive agent that takes a couple weeks, almost a month to get ramped up for effectivity or effectiveness.
And renally excreted, so more at risk of bleeding. And
good point. I always forget that. You guys always tell me, well, now the create's going up, and I'm like, oh yeah, I always forget that. So,
but that was very interesting when we talked about that in Boston. The fact that in human medicine they use a lot of cyclosporine, and that we sort of poo-pooed with this old study saying that it wasn't really working. But that's also definitely a study that needs to be repeated, ideally.
I agree. And having a study, and the study that we're talking about, I'm 99% sure we didn't know the diagnoses for all those dogs, that we just knew they were proteinuric. And proteinuria didn't response. We
actually knew they had glomerular disease, but they were non-amyloid, but we didn't characterize them back as much as we could have. And the other thing about that study is that so that was my residency project. So
I know, I was like, I know Dr. Vaden's still on here.
But that the other thing in that study that we did was we used the kind of original formulation, which was very irritating GI wise. And so at the end of the study, a lot of the dogs that got the control, the placebo, had a lot, which was just the carrier, had a lot of I have to think back to how the study was, but there were GI side effects that could have been associated with the carrier. So it was between the GI side effects, the not eating, and the fact that they weren't doing well in dogs that were just listed as having glomerular disease in a time where we didn't even really acknowledge FSGS. So I think that study does need to be repeated, but it is the only study that we have. It needs to be redone. And, the thing about the cyclophosphamide is if you look in humans, they use chlorambucil. They don't really use cyclophosphamide because they think the risk of neoplasia is better. And so I think a lot of times when we look at those studies, we don't translate them in our head that we could try cyclophosphamide instead. And I do think it's a reasonable choice. It just wasn't where we landed. But again, that doesn't mean that we were right or that we're not at a place right now where we could gather the data that we have on mycophenolate and try to move forward with different recommendations.
Yeah, I agree. I think at this point, because we have so many repeat offenders for the biopsies, that getting these cases where we have this excellent follow up for like the cases like Sarge, like where we have data, would be a great step. And then obviously seeing what cyclosporin effectivity of knowing which ones are immune complex mediated, and maybe that's what JD will recommend to this clinician as well. But yeah, so I know we're a couple minutes over time and I apologize. And I know I talked really fast, but that's how I get things in for 2 hours. So please send me direct message if you need to be added to the list. Also, please keep in mind when you want to present a case, that's great. And I have the recording. We are still trying to figure out how JD is going to post on YouTube, but he is going to post on a specific link. And that way the recording can be visualized by people who can't attend. But we still need to work out the details for that. And yes, I can stay, Dr. Shropshire. I'm going to stay a moment longer too to talk with Mary and Jessica. So for those of you guys who have attended and stayed, thanks so much. And I'll see you guys next month.